Today, 28th February 2026, Saturday, and from 4 p.m. onwards. Good afternoon, one and all. I am Dr. Bhuvan Nagpal, the founder president of POPMA and host for today's POPMA Study Club. Warm greetings to everyone. It gives me immense pleasure to invite you to today's POPMA Study Club, which is a regular series. And we are honored to have Dr. Potsangam Aparna Devi ma'am from Imphal as our guest speaker. She will be delivering an insightful session on pitfalls in the diagnosis of Ameloblastomas, a topic of great diagnostic significance for every practicing oral pathologist. Ameloblastoma remains a lesion where histopathological interpretation demands precision, clinico-radiological correlation, and scientific vigilance. Today's session will help us refine our diagnostic acumen and strengthen evidence-based reporting practices. I encourage all members, faculty, and PG students to join actively, interact academically, and make the most of this learning opportunity. Let us continue moving beyond the microscope towards clarity, confidence, and clinical excellence. Dr. Radhika is not there. Uh, Dr. Radhika, have you joined? So Dr. Radhika is not there. I will please put your
Here. Hello.
yes, ma'am.
Sir, Dr. Swapnita here. She
Yes,
said
ma'am.
that she will be joining shortly.
Okay, I'll introduce. Okay. So, Dr. Purusangam Aparna Devi, ma'am, who is she is associate professor at Regional Institute of Medical Sciences, Imphal, and she has uh, numerous publications to his credit of national and international repute. She is member of IOMP and POPMA. So, meanwhile, when our moderator will join, I request ma'am to continue. Over to you, ma'am, and welcome to the POPMA Study Club. You can unmute yourself, ma'am. Unmute yourself, ma'am.
Hello,
Yes,
is it audible?
yes, it's audible.
Okay. Good afternoon, respected POPMA members, my dear students, faculties, and senior faculty members. Thank you for having me here. I'm very grateful and humbled to be a part of the POPMA family, the study club regular series. Thank you for giving me this opportunity to share my thoughts and facts on the pitfalls and the diagnosis of ameloblastoma. Greetings from Regional Institute of Medical Sciences, Imphal, Manipur. Tawri, Shitaw.
You can share your screen, ma'am. Uh, meanwhile, Dr. Radhika is here with us. Dr. Radhika, you can introduce your speaker once again, though I have done my bit. Dr. Radhika, please unmute yourself.
Yes, sir.
Dr. Radhika is currently a senior resident at GDC Hyderabad, and she has recently finished her PG. So, Dr. Radhika, you can introduce our esteemed speaker.
Yes, sir.
Dr. Radhika, are you there?
Yes, sir. I want to introduce our today's guest speaker, who is Dr. Po Sangbam Aparna Devi. She is an associate professor in the Department of Oral Pathology and Microbiology from the Institute of Dental Science and Medical Science, Impaha, Manipur. There are various national and international publications to her credit. We welcome you, ma'am, to the POPMA Study Club, and we request you to start with the presentation, ma'am.
Odontogenic tumors can be variably defined as a tumor or a tumor-like growth that have their origin from odontogenic tissues. As we all know, it's because of the heterogeneity among them is the result of varying induction that occurs between the developing embryonic components. The WHO in 2022 defined ameloblastoma as the benign tumor consisting of proliferating odontogenic epithelium in the background of fibrous stroma that is locally aggressive. On this note, I want to add up on the definitions by Robinson, 1937, that ameloblastoma is a unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent tumor. It is the most puzzling of all the odontogenic tumors due to its unpredictable clinical and histopathological behavior. It is the most common and frequently encountered odontogenic epithelial derived tumor of the oral cavity. It is observed to be the most aggressive and hence a tendency to recur in most of the circumstances. It accounts for 1% of all the oral tumors and about 9 to 11% of odontogenic tumors. WHO 2024 classification of ameloblastoma encompasses several types, namely conventional, solid multicystic, unicystic with its subtypes luminal, intraluminal, and intramural, extraosseous, and peripheral ameloblastomas. All the three types of ameloblastomas are defined histologically by the presence of ameloblast-like cells around a loosely attached epithelium that resembles stellate reticulum. Conventional ameloblastoma consists of solid macrocystic and microcystic tumor presenting different histological subtypes with variable presence of ameloblast to support the diagnosis. The unicystic ameloblastoma has clinical, radiographic, and gross features of single cystic structure showing typical ameloblast features on histologic examinations of the cystic lining with or without intraluminal or intramural tumor growth. Now, this is the pitfalls. This could lead to the pitfalls in the diagnosis here. In this point, I will repeat. These things has to be taken into consideration of unicystic ameloblastoma, which has clinical, radiographic, and gross features of single cystic structure, showing typical ameloblastoma features on histologic examinations of the cystic lining with or without intraluminal or mural growth. So we have to be very careful when we get such cases. A subset of unicystic ameloblastoma has been reported intraluminal plexiform epithelial proliferations that lacks ameloblast-like features. The diagnostic feature of ameloblastoma should be sought elsewhere in biopsy to distinguish from the non-neoplastic josses with florid epithelial proliferations, which requires less aggressive treatments, or else the treatment will go in another aggressive direction. Unicystic ameloblastoma can be subdivided into three types. I'm just repeating the slide again, namely the luminal, intraluminal, or intracystic, intramural, or infiltrating subtypes. The intramural subtype seem to be more aggressive than other subtype requiring aggressive surgical treatment and long-term follow-up. As we all know, this is the histological variance of ameloblastoma namely the plexiform ameloblastoma, the follicular ameloblastoma, acanthomatous ameloblastoma, the desmoplastic ameloblastoma, the granular ameloblastoma, basal ameloblastoma, basal cell ameloblastoma, papilloferous keratoameloblastoma, the pigmented ameloblastoma, and the hemangiomatous ameloblastoma. And today I'm bringing two cases of plexiform ameloblastoma for us to discuss. This is my first case presentation where the male patient of 50 years old came to our dental college with the chief complaint of swelling in the left side of the cheek, which is around 4 to 5 centimeter in diameter and which is hard, non-tender on palpation. On intraoral examination, here we could see an ulcer on the left in the left buccal mucosa in the area of 3-7. This is the OPG picture where we could appreciate the multilocularity of the lesion, which affects the coronoids and the buccal plates with impacted 3/8. This is the CT scan again, where we could appreciate the multilocularity of the lesion. After incisional biopsy, we came to the final diagnosis of plexiform ameloblastoma. Here we could see the high power and the low power with the squamous metaplasia. This is case 2, where we have a 27-year-old female patient who came to our dental college with a chief complaint of swelling in the right posterior mandibular area. She had a history of surgery done in 2016, and after which the swelling has recurred since 2 years. And on extraoral examination, the swelling was indurated but non-tender, roughly about 2 into 3 centimeter in size. On intraoral examination, there was a swelling of around 5 into 4 centimeter in size in the right posterior mandibular region. This is the OPG of the same patient where we could see the destruction of the bone with the multilocularity and again this is a CT scan of the same patient. This is another CT scan where there is buccal cortical plate expansion. Now, here I want to discuss with all, like I'm focusing to more of the PG and the UG students, where after incisional biopsy, we could see this structure, this feature, where we could see a varied feature of this follicular pattern, plexiform pattern, the follicular pattern with squamous metaplasia and keratinization in the center of the follicle. Then this is the higher magnification where we could appreciate the pleomorphism, cellular and the nuclear pleomorphism, and other features of malignancy with areas of necrosis. After which we have given a diagnosis of ameloblastic carcinoma. My take-home messages would be odontogenic lesions, whether reactive, developmental, or neoplastic, can cause diagnostic uncertainty. We should take time to explore the clinical and the radiological features of the lesion for accurate diagnosis. Clinical and radiological correlations within the whole team of oral medicine and the surgeons and the pathologists is mandatory and is a must. We should not hesitate to ask for further biopsy of a cystic lesion in the jaws if the biopsy is small and histological features is not appropriate. Sometimes the classical histology of a rare tumor can strike fear into unexperienced or budding pathologists or young pathologists. So always We should be wise enough in such circumstance to seek the opinion of mentors and colleagues who are more experienced in odontogenic lesions. The assessment of malignancy in destructive odontogenic lesion is challenging. The specimen should be widely sampled with assessment of proliferation as well as aid in the overall consideration of malignancy. Thank you.
Yes, ma'am. Have you finished with the presentation,
Yeah, I have
or
finished with the presentation, but I want to
yes,
continue
ma'am.
with the discussion. Yes.
Yes, ma'am. Please. I request Dr. Radhika to moderate the session. Dr. Swapnita, you can also take part in that. And it is open to everyone, those who want to discuss the case inputs. So you can unmute yourself. Yes. Now please try, Dr. Radhika.
Yes, sir.
You can unmute yourself, Dr. Banerjee.
Yes, yes. Sure. Thank you.
Initially, because when people they start entering, no, so there's a disturbance, so you have to give that command. But now it's open for discussion.
Yeah,
I
I have a
think
question to Dr. Aparna.
Yes.
yes, please
Yeah.
go ahead. You can ask live only.
Yeah, Dr. Aparna, I just joined late, but I joined exactly at the moment of our histopath discussion. So it's a wonderful case. I just want to ask, did you see any necrosis or any other areas in that particular case?
Yes, we have evident necrosis in this case of malignant ameloblastoma.
Okay,
Sorry,
okay.
ameloblastic carcinoma.
Okay, okay. Thank you, thank you.
Thank
Ma'am,
you.
do you have any case of adenoid ameloblastoma?
No, we don't have.
Okay. Yes, Dr. Radhika, please go ahead.
Yes, thank you so much, ma'am. It was such a wonderful presentation. As ameloblastoma, it looks clear, but it's not very simple in terms of diagnosis. We have so many various subtypes of ameloblastoma being added in the recent classification, like adenoid ameloblastoma. Being a just postgraduate student who has passed out recently, I particularly don't have that clarity and confidence when it comes to adenoid ameloblastoma because the reported cases are very less and haven't been fortunate enough to have a look. So, when in benefit of doubt, how do we come to a diagnosis? If we can say two or three patterns in a single case, uh, how should we give a diagnosis, definitive diagnosis in such cases, ma'am? Like at a foci, I can see
Actually,
follicular. I can also see
yeah,
plexiform. Um,
yeah.
then how do I mean, I saw a case, ma'am, where 98% it was follicular and only at a foci it was plexiform. Then shall I go with hybrid ameloblastoma or shall I only stick to follicular ameloblastoma?
Actually, that is the thing I wanted to discuss with the PG crowds because for me, this case was more looking like ameloblastic carcinoma. But uh, what would you give your like for your opinions? Will you give it as an hybrid ameloblastoma? In my case, in this case, because we could see the follicular pattern, we could see the plexiform pattern. So I wanted to put this question for discussion actually. So
I have to
for
say
me,
something it's like, see, histopathology is very fancy, and we histopathologists are very fond of different terminologies and all when we come. and we satisfy ourselves. So if we actually go with the multiple opinion of the different foci, I think first gold standard is like we have to rule out whether it is a benign or a malignant condition. Number one point, because if the ultimate goal is to explain or communicate with the surgeon and look for the prognosis of the case. Yes, we can go with multiple flowery terminologies for our publications and all, but probably what is the more predominant areas, and if there is the rightly Dr. Aparna has shown few areas of where the pleomorphism and the dysplastic changes that have happened in the case, that will lead more onto the malignancy. Now coming on with the adenoid cases and all, yes, if the initial phase, if for myself, I am talking about myself from 2017 onwards, whatever my private practice of oral pathology is there, I have never seen an adenoid ameloblastoma. So probably the first case of adenoid ameloblastoma, I would go on with the multicystic or pleomorphic or plexiform ameloblastoma, but it will not hamper the patient in much or any way, means in a major way. But yes, getting an expertise of identifying one case or two case or three case of adenoid ameloblastoma, coming to a conclusion, probably for the next few cases, then we can just we can recognize adenoid ameloblastoma. Otherwise, if we actually go with the medical pathologist report, there is no more classification other than odontogenic tumors only. If Dr. Bhuvan and Dr. Aparna and many other pathologists will agree to me, they don't even classify into much other classification. It's only oral pathology because our domain is like that, and we are taught in the multiple classifications. And also, I think the more predominant sections is number one, and number two is going with the dysplastic changes that can actually look into the diagnostic part. Thank you.
Dr. Abhishek, I would like to add something. Like as you rightly said that we need not go for any flowery kind of terminologies. The first thing is benign and malignant because as Dr. Anita Borges rightly said that we have to work like a pathologist but think like a surgeon. So what is going to be the outcome? Now the question is sometimes adenoid ameloblastoma it gives a picture of MEC. So you have to differentiate, and in my practice of last 10 years, I have seen only two cases. So the reason was is just that because unless until we classify uh, in some of the cases, ameloblastoma is fine, everybody will know, and that is right also. If we are classifying, because what happens sometimes the for the second opinion, the person will not be knowing okay such kind of a variant is available or not. I hope my message is clear, which I wanted to say. Rest, all your take and things are already they are commendable. You are also, in a private practice and doing lot of cases for oral pathology. Thank you so much. Over to you, Dr. Radhika again.
Yes, sir. Actually, I have one more question which I would like to ask regarding ameloblastoma. Uh, Ma'am, is it okay if I ask?
Please continue. Yeah, please
Yeah.
continue.
In my department, I saw a case where there was turning of OKC into ameloblastoma. So, while giving the final diagnosis, should I mention that this particular ameloblastoma has been transformed from OKC or just I give the diagnosis? Because somewhere in some reports in my department, I saw the pathologist writing OKC.
Dr. Radhika, we lost connection from your end. I think you have internet problem.
Am I audible, sir?
Please repeat your question again. Dr. Radhika,
Yeah, I
kindly
can
repeat
hear
your question
Radhika. I
again
can hear Dr.
as we
Radhika.
lost your voice in between.
Okay. Am I audible now, sir?
Yes, yes, yes. You are audible.
You're audible.
So my question was, if one particular variant transforms into other, so we have to mention in the final diagnosis, or it is just for the information? We did not include in the final diagnosis. That was my question, ma'am. Like OKC
May I
turning into
tell?
ameloblastoma.
Yeah. So, Dr. Radhika, it's like which you think like more aggressive, a OKC or a ameloblastoma? Just for a discussion sake.
Sir, I um both are aggressive, sir. But if you ask me as a postgraduate, I would answer OKC because I have read so much in Rykart and other things. Sorry, in Shear. Like now, there has been a change from KCOT again back to OKC because there is presence of satellite
Yeah, that is
cysts. There is
what I am asking. Actually, rightly, Dr. Bhuvan has just pointed out, Dr. Borges, one this we have to think like a surgeon. Like when we actually go with the OKC, like a general, I'm not talking about you are a very big specialist or you are a PG or a faculty. I don't know. It's just like OKG and ameloblastoma. Suddenly, a patient comes. See, this is the OKC, and there is a patient which comes. This is the ameloblastoma. You just hold your breath when it is like OKC. Chalo. At least we can go with certain amount of nuclear multiplication. We can keep a patient in the follow up and on. But for generally the definition of ameloblastoma goes with the benign and locally very aggressive lesion. It leads to the eating away of the entire mandible or the maxilla, whatever. It goes for a big segmental resection of that area, right?
yes,
So,
sir.
a OKC transforming into a ameloblastoma, it gives a clue about its potential aggressiveness. You can definitely mention. But for a surgeon, when the final outcome is the case is ameloblastoma, whether it has turned from a OKC to ameloblastoma, or it has turned from a dentigerous cyst to ameloblastoma, or from a radicular cyst to ameloblastoma, I don't think surgeon will differ in their treatment plan in a big way.
Yes, yes.
If I am
Dr.
wrong, you
Abhishek
can.
is rightly pointed out. For the surgeons, it is the same. It is. It doesn't make much difference.
This is a very important point, Dr. Radhika, because you are a budding oral pathologist, and what Dr. Banerjee has said, you should note down his words. This is gonna actually affect because when a surgeon sends you, he does not want you to publish that article. Okay, he want a diagnosis. He really wants a diagnosis because that's gonna affect the treatment plan. So. Podium is open. Anybody who has any question, they can ask. And
See, this is what like such a short presentation can actually raise so many questions in one person who is actually starting the career. And I think most of the questions remained unanswered because of the syllabus pattern or because of the whatever curriculum pattern. But actually, we should think practically. I think that will help everyone a lot.
Yes, sir. It's rightly said. That's why it's said that theory is completely different from practical. Practicality needs experience,
Yes,
which
yes.
which you
you should
people have,
also
sir,
know
and
how
we
to
should.
apply your knowledge, your theory part into the practice. That is also important.
Yes, sir. Basics are surely important, but we need to be under the guidance of experienced pathologists like you all, sir, so that we don't commit mistakes and we learn from your wisdom.
Absolutely. Even we are also not that old in oral pathology. I think
Even
Dr.
if it's
Aparna,
old or
myself,
not,
Dr. Bhuvan, we are all
everybody
here.
makes a mistakes and everybody
Yes,
learns
yes.
every day.
Actually, we all are learning.
Yes.
Yes, we are all learning actually. So we like something. See, this is a question when it is which you have raised. Actually, we also have to think about what reply we have to give so that we can do justice to your question. So that is also a thought process. So that is what a good one, good one.
Thank you,
May
sir.
I ask something?
Yes, yes, doctor. Please proceed.
Actually, in many cases, there are some ambiguity between the infected dentigerous and the unicystic ameloblastoma. In infected dentigerous, many a times it happens that the lining epithelium becomes spindled and may mimic the stellate reticulum like. And in those cases, and the lesions become big also, much big. And in those cases, what factors should we take into consideration to differentiate it whether it is infected dentigerous or unicystic ameloblastoma? Over.
I didn't get the question. Please, can you please repeat?
Ma'am, may I repeat the question? The
Yeah,
question
yeah.
is, he wants a certain criteria to differentiate between infected dentigerous cyst and cystic ameloblastoma because they might mimic each other. So, is there any criteria we should look for to distinguish between both the lesions? That's the question being asked, ma'am. Infected dentigerous cyst and cystic ameloblastoma.
In infected diseases, when we look into it, we will be seeing lots of inflammatory cells also, right?
Yes, ma'am.
Yeah. Uh,
I think when there's a inflammation, it's always we have to a lower diagnosis because inflammation is kind of a googly which can always make us wrong. So whenever there is an inflammation, either we have to go for a lower diagnosis or probably we have to sit across a table in a pentahead or something and we all have to come into a opinion and then we can deliver a report. Like during inflammation there are a lot of places, like even in inflammation I have particularly seen a granulation tissue which is excavated from a socket, and a portion of the gingiva it comes out along means inner lining of the gingiva, it comes out with the granulation tissue, and it exactly mimics a stellate reticulum kind of this thing. But there we have to because this is where I was stuck once, and I was about to give it as an unicystic ameloblastoma in developing stage. But that time Dr. Kavita Chatterjee ma'am has told that look at the overall view of the epithelium. And what ma'am has pointed out that there are few areas where the desmosomal junctions are still intact. That means it is a squamous epithelium more than a odontogenic lining or something like that. So I think we have to sit across and we have to see such slide and come to a common conclusion.
Sir, won't radiographic features aid in differentiating the both to a certain extent, not a complete extent, but maybe to a
Yeah,
little extent?
radiographic is always ancillary tool. Yes, definitely. But I'm what Dr. Ghosh has rightly pointed out. Inflammation, there is inflammation can make any lesion or disease look horrible in a horrible state, right? So once the inflammation goes down, probably many things settle down. So radiograph is not always a criteria for that. Suppose a patient is having a gutka chewing habit or a khaini chewing habit. I'm just giving an example. A khaini chewing habit, keeping the entire quid into the canine to second premolar region in the lower vestibule, and the due to periodontal bone loss, there due to periodontitis, chronic periodontitis, there is a big bone loss, massive bone loss, and on top of that there is a dysplasia and there is a early squamous cell carcinoma. Now when we go for a 2D imaging or like a two-dimensional imaging with the OPG or something, we see a periodontitis and we see a squamous cell carcinoma. Now how to distinguish between both, like whether it has invaded the bone or how? So there I think there we have to sit quietly and we have to see the other features like rugged broader borders and histopathologically what is the extent of the like what not histopathologically, yes, histopathologically what is the
the
extent,
clinical
clinically
correlations
also what is
also.
the
Yes,
extent, yeah,
yes.
that all I think we can do.
Yes, sir.
Dr. Radhika?
Yes, sir.
Dr. Radhika. Dr. Nandini ma'am wants to talk something. She want to add. Nandini ma'am, good afternoon. You can unmute yourself, ma'am.
Yes, ma'am. You can ask your question, ma'am.
Good afternoon, Dr. Bhuvan, Dr. Abhishek, and Dr. Aparna. Nice
Good afternoon,
presentations
ma'am.
and
Thank
nice
you, ma'am.
discussions,
Thank you,
everyone.
ma'am.
There are certain things which were discussed, dentigerous cyst and unicystic ameloblastoma. How do you differentiate? Dentigerous cyst, if it is inflamed, you'll have inflammatory cells, and of course, the epithelial lining is quite unique. You will not see tall columnar basal cells and that type which is seen in unicystic ameloblastoma, for which you have to apply Vicker Garlin's criteria. So that will not be there in your inflamed dentigerous cyst. So, and apart from that, radiographically you should have an impacted tooth for dentigerous cyst and not necessarily for a unicystic ameloblastoma. So there are certain clues for that. So I think I have
Right.
cleared few things.
Thank you, ma'am.
Then apart from that, for adenoid ameloblastoma, you will have a different pattern of arrangement of the epithelial cells. It is in the form of a glandular area. Cribriform means that
Yes.
hole-like or sieve-like areas. So in cribriform ameloblastoma, you will have glandular arrangement of the epithelium. So apart from that, dentinoid is a must to diagnose adenoid ameloblastoma. The dentinoid formation should be
Yes.
there. Unlike in other forms of ameloblastoma, other variants, it is not required. And of course, there is a no clear-cut definition. Hybrid. If you see the meaning of hybrid lesion, means a lesion which is displaying uh, one or more
The features.
types of histopathological variants is called a hybrid lesion. Actually, ameloblastoma, if it shows plexiform, follicular, acanthomatous all together in one, ideally it should be called hybrid. But most of the pathologists, even I had a doubt initially. So when I, asked some senior fellow colleagues, they told that for ameloblastoma, they don't write it as hybrid. Rather, they just describe the predominant pattern and the pattern of invasion. So that is it. So there is no proper hybrid or not hybrid. That terminology is not mentioned for ameloblastoma. Is
Right,
that
ma'am.
clear, Dr. Bhuvan?
Yes, ma'am. I have reported two cases. One came as for second opinion from somewhere, and it was MEC. They have signed it out, but I signed it out as adenoid ameloblastoma, as you
Yeah,
features you were mentioning.
yeah.
That
For
was intro.
MEC, you should have, yeah, you for MEC you should have mucus cells and intermediate
Yeah,
cells
right.
and
But it
huh,
was glandular pattern, but the cells were stellate reticulum
cells.
and
Yeah.
all tall columnar, all the features of ameloblastoma were there in that, along with
Sometimes
dentinoid.
salivary gland tumors show, similar sort with odontogenic.
Yes,
We have to be
that's
very
why when
careful.
because I give photographs, photomicrographs along with my reports, and not just a single one, but maybe some 15, 16, 17 like that. So
Okay.
then the things got clear. Yeah.
Yes, yes.
I've reported two cases, ma'am, as of now.
Okay. We have a recent case of adenoid ameloblastoma, or just couple of days before.
Okay. It's bit of more the aggression is comparatively high, ma'am. What the studies have
It looks
told.
more like
What is
adenoid
your take
cystic,
on it?
Yeah.
Yes.
When you look under microscope, it looks like an adenoid cystic in the initial. Suddenly,
Yes.
you get confused with
Yes.
the salivary gland. Maybe it is intraosseous. That also you have to take into consideration.
Right, ma'am. Right. So nice.
Thank you.
Thank you so much,
Ma'am, we
ma'am.
want a class from you, one study club from you,
Okay,
Yes,
okay.
definitely, ma'am will come.
exclusive on
Hopefully, ma'am.
ameloblastomas.
We would love to
Arrange,
see the case of adenoid ameloblastoma, ma'am.
Sure, sure. We will arrange for it. Even Dr. Bhuvan's case and only adenoid only we
Yeah,
can
I'll
make
share
as
my case also. No issues
so all the
for that.
cases of adenoid you can just compile and you can do it once.
Yes,
Yeah,
ma'am.
yeah.
One special study
But
club
anyways,
only on adenoid ameloblastoma.
It is still very new entity. It should get its own
yes.
recognition, in fact.
Yes, ma'am.
Very less cases have been reported, ma'am. I have also sent it for publication.
Oh, good, good.
Yeah. Okay.
Thank you.
Then
Thank you, sir.
anybody
Thank you,
would.
ma'am.
Thank you, ma'am. It's our pleasure and honor that you attended our session and you are there to guide us. Now it's open to other members. Anybody would like to give any input, or shall we wrap up? Okay. So, Dr. Radhika,
Yes, sir.
please give vote of thanks. Thank you so much, ma'am, for your valuable input. Uh, Dr. Parna, ma'am,
Thank you.
for
Thank you.
sparing your time. Yes, Dr. Radhika, please go on.
It's my honor to present the certificate to Dr. Aparna Devi for sharing her valuable knowledge in the guest lecture on pitfalls in the diagnosis of oral ameloblastoma. And this particular certificate is being awarded by POPMA governing body. Ma'am, we would love to have more study sessions with you, ma'am. And it's been honor. And I would say this study club will be very academically useful to all the postgraduates and also the working oral pathologists. Thank you so much, ma'am.
Thank you.
Okay.
Thank you.
Now I request Dr. Abhishek to please present the certificate of appreciation to our moderator, Dr. Radhika. Dr. Abhishek.
Thank you,
No,
Dr.
Dr.
Aparna, and thank you, Dr. Radhika.
Thank you.
So I request everyone to please put on your cameras. Ma'am, please stop sharing the screen from your side.
In the top.
So I request everyone to please put on their cameras. If yes, we can have a group photograph. I have already posted the links to subscribe our channel. This video will go by tomorrow on the channel of POPMA, the official channel of POPMA, and a small announcement that we are conducting our second national conference, that is PopCon, Practicing Oral Pathologists Conference. So that is the short form PopCon 2026, and that will be from 2nd to 4th October. And you will really love, you can take feedback from the persons who have attended last year, and uh, if you are interested, the link has been there in the description and in the chat box. So would definitely love that everyone can attend. Thank you so much. And a small photograph. Please say oral pathology. One more.
Pathology.
Oral pathology.
But sir, your picture is no. Okay, Dr. Chatterjee is there. Yes. Thank you. Thank you so much, everyone. Uh,
Thank you.
so we'll come up with the next POPMA study club next month, and we'll increase the frequency from two study clubs a month. Though we were conducting, but from past 2 months, there were a lot of other UG and PG student activities were going on. That's why. And yes, before I forget, Happy Oral Pathologist Day to all. Thank you so much,
Thank you, sir.
and
Thank
stay
you, sir.
tuned
Thank you,
for all
Chetty.
the updates. Yes, and those who are interested to become member, they can also visit our website, which is popma.in, and you can find all the details there. Thank you so much, and stay tuned for all the updates. Bye, bye, everyone.